then, Dr. Pirio Richardson, I'll turn the floor over to you. And I think you are muted, so don't forget to unmute.
Okay, thanks very much for the introduction and the challenge, apparently. I'll do my best. So what I'd like to do today, I was asked to talk about medication management tips and strategies. And so I'm actually going to share my screen and go through a little bit of a presentation while I talk, just to make sure that we're all on the same page in terms of some knowledge of some basics of the medications and also some strategies and tips. And then I'll go ahead and take that back off, and I'm happy to take questions at that point. So I'm going to go ahead and share my screen. All right, so you should see my first slide here, and I'm going to, as she said, I work both at the university as well as at the New Mexico VA healthcare system. So what I'm going to do is cover common Parkinson's medications and side effects. And there definitely will be medications that I'm not covering that you may be taking or have questions about, and I'm very happy to take those during the question time period. I'm going to talk briefly about medication interactions, some that I think are really important for you to know about, and then spend some time thinking about maximizing benefit of your medications. So in terms of the motor symptoms of Parkinson's, I don't think any of this will be a surprise to you. There's the 4 cardinal symptoms, which are the bradykinesia, or slowness of movement. There's the rigidity or stiffness of movement. Tremor can be present as well, which is that involuntary shaking of the hands, feet, arms, leg, jaw, or tongue. And then people can have a postural instability or tendency to fall. And what we know, especially with the bradykinesia, the slowness, as well as the stiffness, and for many people, the tremor, all are related to this loss of dopamine. It's clearly not as simple as that, but there is this clear link in relationship to a loss of dopamine causing these symptoms. So as a result, our idea is to increase dopamine. We primarily use levodopa, which is converted in the brain to dopamine. And we also use dopamine agonists that mimic the action of dopamine in the brain. And by increasing the levels of dopamine, our goal is to decrease symptoms. And the ones that primarily get better with this approach are that we can reduce slowness, so we can make movements faster. We can oftentimes reduce tremor, although it is absolutely true that there are patients with a Parkinsonian tremor that do not get response from dopamine medications in terms of treating their tremor. And then stiffness. So those are the 3 symptoms that we expect to get better with increasing levels of dopamine. The challenge, of course, and I'm sure many of you have experienced it, is as we increase dopamine with these agents, we can also increase the chances for developing side effects. And the ones that we primarily associate with dopamine-related medications include sleepiness, and that can be, all over complaints of fatigue. It can also be 20 minutes after taking a dose of levodopa, people can want to take a nap. They're really tired at that point. Hallucinations, or seeing things that aren't there, can occur with increasing levels of dopamine. And then fluctuations, which is this phenomena that when you take a dose of medication, motor symptoms get better, last for a few hours, and then the motor symptoms then return, the stiffness and slowness comes back, have to take another dose, and you repeat that same cycle throughout the day. And then finally, dyskinesias, which are those extra wiggly movements that can come from increasing dopamine levels. So we want to increase movement, but we can overshoot that and cause some extra movement that we're not interested in. So I want to go through the levodopa preparations that are currently available, knowing that there are some new ones that were just recently approved, and we'll touch base on that as well. So in terms of right now, we have an immediate release levodopa preparation. Its trade name is Cinemat. That comes in 3 doses, and you can see that wide range of typical regimens from very low to high, and certainly can go higher than that on an individual basis. We have a continuous release preparation. It also sometimes says SA, or sustained action, on it, and that's a longer acting preparation of carbidopa levodopa. There's a preparation of levodopa called Stalevo, is the trade name, and it combines carbidopa, levodopa, and entacapone. And entacapone is a medication that can allow the levodopa to last a little longer in the nervous system. There's also a new, within the past couple of years, a new carbidopa, levodopa extended release preparation called Rytary. And then finally, we can also deliver carbidopa, levodopa through the gut with a pump that can put, and a feeding tube that can put the levodopa gel directly into the gut where it can be absorbed. The biggest side effects related to carbidopa, levodopa are listed in the far column. We have low blood pressure, and that may not cause any side effects, but the most worrisome side effect that can occur is fainting, and that's our big worry with that, with people having low blood pressure. It can cause nausea, and we'll talk just a little bit about that in a minute. It can cause some confusion, and of course can cause those extra movements or dyskinesia. Those side effects are the same for all these preparations of carbidopa, levodopa, with the exception of Stalevo, which can also cause diarrhea. So I just mentioned that out separately. So in terms of the dopamine agonists that are currently available, we use ropinirole or Requip, and there's also pramipexole and Mirapex. Those are pill form. And then we have Nupro or that one's too hard for me. I'm sorry. I did get stumped by that one. I just cannot pronounce it. We're just going to go with Nupro. I try not to use the trade name, but it's what happens. And its side effect is similar to the oral medications, which again can cause low blood pressure, nausea, confusion. Sleep attacks are sort of an extreme sleepiness that can occur with our with our dopamine agonist. And compulsive behavior is also something that can sometimes be associated with these medications. And the only other one that I mentioned on there was rash with the Nupro patch, and that's because any kind of adhesive, people can get a skin rash too. And then the other dopamine agonist that we have currently available is currently right now as an injectable form, but may come out in a different form shortly. And that's for short-term benefit in terms of helping motor symptoms, and its biggest side effect is nausea, so it typically has to be taken in concert with anti-nausea medications. So, you know, levodopa has been available for quite some time, and although we have a lot of other medications that we use sort of as adjuncts to help levodopa work, it's still the one that we talk most about. And the reason for that is the Parkinson's Outcome Project recently looked at a study where they asked folks who were coming in to see their doctor whether or not they were using levodopa or not. And what you can see is that if you go back to the last visit of a large number of, these are all patients who are coming to Parkinson's Centers of Excellence, 88% of them at that particular visit were using levodopa. So it's really a commonly used medication for Parkinson's because it really does give motor benefit. 9% were not using it. So again, a small percentage were not using it. 2% were starting at that visit, and 1% were stopping at that visit. So again, it's a very used medication, which is why we're talking about it. I said we talked just a little bit about that nausea, and just so that you know the term of where the name came from, synemet, it comes from the Latin, which is syn, meaning without, and emet, which is vomiting, or emesis, which is vomiting. And so that's where that came from. And that's because if you take levodopa by itself, it will absolutely induce nausea and vomiting. So it's combined with carbidopa to reduce the chances of you having nausea or vomiting with the medication. And I bring that up because if you are having trouble tolerating it because of those side effects, there are ways that we can try to help by either increasing the amount of carbidopa or using a different preparation that you may actually tolerate it. So I want to make sure that that's in the back of your mind, that we often are able to work around that and help that medication be tolerable to people. And so I think the take-home key is that although we've had a lot of advances and there's exciting things coming up, levodopa is really still the most effective medication for motor symptoms that we have right now. So in terms of some keys to take away in using levodopa, typically to minimize side effects, you start low and you use the lowest dose you need to control your symptoms. We increase slowly to benefit. And this issue of avoiding protein and why we have to move this around meals is because levodopa or dopamine is a protein, and once it's broken down, it's an amino acid, which are the chemicals that make up a protein. And so our gut is primed to take proteins up from our diet so that we can absorb the protein, take advantage of that nutrition. So we're competing with other proteins in our diet when we're taking levodopa. And so that's why we talk about trying to make some time or space from eating meals, especially with protein, just to allow the maximal absorption of the levodopa, because otherwise they're in competition. And then I already mentioned this point, again, if there's nausea, there are ways that we can add extra carbidopa to make it tolerable. So that was very brief, but just over levodopa and the different preparations, as well as the dopamine agonist. There are other medications out there that I'm sure many people are taking and may have questions on, and I'm very happy to talk about them, but wanted us to have a base because most people are taking levodopa. I'm going to move now to just focus on a few interactions, some common interactions with Parkinson's medications that I think are worthwhile mentioning. I wish it was funny. They're not. When medication interactions occur, they really can be serious. But I'm going to focus on things that make levodopa less effective, can cause more side effects, make it more intense. So we'll first focus on what interactions can make levodopa less effective. The big ones, and I'm sure you've seen the warnings if you have a cold or a cough and you try to go to the pharmacy to get an over-the-counter cough or cold medication, it says if you have Parkinson's disease, consult your doctor. And this is part of the reason, is that they can make levodopa less effective. This is not a dangerous interaction in general. You're still getting some of that levodopa in, but your symptoms may not be as under good control. The challenge there, of course, is when you're sick, your symptoms are always worse, and so it's a little hard to tell. So it's not a dangerous interaction, but again, it can make levodopa less effective. That's true also for medications that are used to treat stomach cramps. The same thing can be true, that it makes levodopa less effective. Anti-allergy medications can do the same. And then this is especially true for sedative medications. And these are the benzodiazepines like clonazepam or Klonopin, Ativan, or Xanax, Valium, all of these medications. Sometimes there's very good reasons for using these in someone who has Parkinson's, but it does make levodopa less effective. So we have to pay attention to that and whether we need to adjust the dose of the levodopa. And then some multivitamins, including vitamin B6 and iron, can also interact and make levodopa less effective. So just something to think about, and especially if you change your medication regimen or supplement regimen and feel like your symptoms are not under good control, it's worthwhile bringing in all of those medications and supplements to make sure that we might not have a medication interaction there. And then there's a few things that can actually make the actions of levodopa more intense. And that includes blood pressure lowering medications, sedative medications, and alcohol can all make the drowsiness of levodopa more intense. That's for the sedative medications and alcohol. So it's not a direct interaction. It's just that sedative medications make you more drowsy. Levodopa makes you drowsy. So we're amplifying the effects by adding them together. The blood pressure lowering medications is the same thing, that the side effect of levodopa can lower your blood pressure. Then when you add on blood pressure lowering medications, again, we're adding on layers of blood pressure lowering. And then the key medication interaction that we really should pay attention to is this one here. And this is really the reason that there's the warning on cold and cough medications, is for people who took these medications, especially the medication selegiline. We don't use it quite as often as we did in the past because we have alternatives such as rasagiline, and we now have Xadago or sulfonamide available. And the issue there is that those particular medications, the MAOIs, so selegiline, rasagiline, or Azilect, or Xadago and sulfonamide, can interact with anesthesia, can interact with antidepressant medications and cold and cough medications, and cause serious side effects and actually might result in you going to a hospital. And so that's why the real warning is on the cold and cough medication. So in general, I tell people that if you're taking levodopa and you need to take a cough medication, that's fine. It may make the levodopa a little less effective, but if you need to control your cough so you can sleep at night, that's a reasonable trade-off. But for these medications, they really should not be taken in combination, especially the selegiline, maybe less so for the rasagiline and the sulfonamide, but there's still some warning, and your pharmacist will still counsel you to avoid that particular interaction. All right, so I'm gonna finish on just a few points, I think, on maximizing benefits or how to get the most from your PD medications, and then we'll end with a few action items, and then I'll open it up to questions. So I always remind patients, I'll read you this cartoon. It says, right now I take a blue pill, a purple pill, an orange pill, a white pill, and a yellow pill. I need you to prescribe a green pill to complete my collection. And I always tell people that taking meds is not a hobby, right? If it's not doing the job that's intended to, or you're having side effects, we really need to be adjusting and working on that. It's not a hobby. You're not collecting medications. They really should be there for a reason and be improving symptoms with minimal side effects. So I think the first thing that you really want to do when you're leaving the office is really understand what to expect with the prescribed medications. Sometimes we miscommunicate where I'm working on trying to help tremor, but the patient is really thinking about their fall risk and wanting to reduce their fall risk, and the medication I'm prescribing really is focused on tremor and not falling, and sometimes we miss that. And so when patients come back, they don't think that it helped because we didn't communicate well about what the medication was for and what the expected benefit might be. You always want to know whether you need to take it with food or without food, and that's particularly important for levodopa containing preparations. Should always have a good idea of what the potential side effects are and not just rely on reading that very long insert that comes with the medication that can be terrifying, but really want to know what the real side effects are that we see most of the time. And then again, will it interact with other medications? The second sort of step that I would use to think about maximizing medications is pay attention to how you feel after you take the medication. Often when people come back and I say, is it helping? They say, I'm not really sure. And again, maybe we didn't communicate well enough, or I didn't communicate well enough about what symptoms I think might get better, but we really want to know, how is it helping? How long after you take the medication does it start working? And how long does it work for? I don't think you necessarily have to do a diary on all of this all the time, but this is really where you're going to get the most out of your interaction with your doctor, is if you can come armed with some of this information. I think we can try to maximize or improve the benefit that you're getting out of your medications. And then I think this is really helpful, is using one pharmacy if at all possible. And I know sometimes it's not. There are certain medications that have to be mail order. There's some that are more convenient to get down the street. But it really does allow a double check, right? Not only me making sure that everything's not interacting, but also allowing the pharmacist to play their important role, which is to make sure that there's not expected side effects or interactions from the medications that you're already taking, especially if there's one that I'm not aware of. So to me, I think this is a really nice safety net that we really should take advantage of. And then, you know, Parkinson's, taking meds for Parkinson's disease, especially levodopa, because it is so short acting in the nervous system, requires multiple doses per day. And it is hard to remember to take it all of the time. So people often will use cell phones or watches to set reminders. It's not uncommon in my office while I'm in the middle of a visit to have a phone reminder going off or a watch going off, and I don't mind those intrusions at all. I think that's great that people are trying to maintain some system to keep the medication timing accurate. It's not easy. So I'm going to end here with, you know, our hope in the future is that we will have a one-size-fits-all pill. This is a cartoon talking about a pacemaker for your heart, but you could also download apps for your liver, kidneys, lungs, and pancreas. All right, so I'm going to stop my share and move back into the conference and see if there's any questions.
Thank you so much. I love your cartoons too. Those were sometimes humor's best way to you know, communicate certain concepts, and those were very well chosen as well. Okay, there, I think I have now, you're on the big screen, spotlighted. Okay, so we had a question. So it looks like this is from a care partner. So my husband isn't always good at communicating side effects. He likes to tough it out. How can I communicate the side effects to the doctor, or maybe you can just share some insight on, you know, when is a side effect something that you just have to, you know, bite down and deal with, and when is it something that you should tell your doctor that it's really interfering with your life?
Right, that's a great question. In my clinic here at the VA, the way we try to deal with that is my nurse goes in first and does a pretty thorough history of how the medications are going and tries to highlight certain side effects to make sure that people know we're interested in knowing about them. They should talk to us about it. And then when they come in to see me, I go through the same procedure. We try to make sure that we give people ample opportunity to talk about them. So I think in general, whether we're talking about medication therapy for Parkinson's or surgical therapy, we're always talking about a balance where we're trying to maximize benefit and minimize side effects, because I'm not aware of any medications yet that don't have any side effects associated with them. We're always balancing that. So I think there's a few things that I particularly look out for. So I think if people are feeling faint when they stand up quickly, that's a side effect that we have to talk about, because it could lead to someone fainting, hitting their head, breaking a bone, you know, injuring themselves in some way. And to me, that's something that we may not need to do anything about it, but we need to know about it so that we can monitor it and give people some ideas of ways to try to mitigate that side effect. But to me, that's number one, that we have to know about that side effect, because there are ways we can treat it. Doesn't necessarily mean another medication. It might mean that we're going to add water and salt tabs or compression hose. We may do something else non-pharmacologic, but that's something I very much worry about. I don't want people to fall, and short of bubble wrapping folks, I don't know how to prevent those injuries. And so that's one thing that I think that side effect has to come out. The other side effect that some people are not aware of are those dyskinesias, those involuntary wiggly movements. They may actually not bother the patient themselves. And for me, that's perfectly fine. I think if the trade-off is you get more mobility and less stiffness, even with some extra movements, I think that's fine not to necessarily bring up or want to address. There are times when those wiggly movements, again, cause you to be off balance when you're walking. And again, I think that's something that we have to talk about and make some choices about. I think beyond that, sleepiness is something that, again, at its extreme can cause sleep attacks, and someone falling asleep behind the steering wheel of a car is not a good thing. Could hurt themselves, could hurt other people. And so that's another thing that I really make sure that we try to talk about, is how much sleepiness is there. I know there's going to be some with any dopamine containing medication, but if we can try to minimize or reduce that, I think that's those are sort of my top three that I think we have to do something about. And it may just be talking and being aware and making some plans, but I think we need to acknowledge them and really pay attention to them.
Okay.
I'm going to add one more, which is impulsive or compulsive behaviors. So these are things like gambling, shopping. Those are also things that we do our best to ask about. And I know that we don't always know what's actually happening, but those are other ones that I think in terms of side effects of medication, we should pay attention to. Okay.
Okay. The follow-up question would be, what about pain and sleep? Those are things that are very subjective, you know, how hard it is for each person to deal with. When should I talk to my doctor about side effects with pain and inability to sleep?
So I think those should come up at each visit. I think I routinely ask about sleep and talk about sleep. I don't always have the right answer for it because it's surprising how hard sleep is, but it is something that I think we need to pay attention to and address. When you don't get sleep, your Parkinson symptoms are always worse the next day, and that continual fatigue plays into worsening of disease. So I think it is something that you should bring up all the time, no matter how mild or severe the symptoms are. It is something we should be paying attention to and at least trying to do something about. Pain is tougher. It certainly is a part of Parkinson's, and it may come partly from some of the stiffness and rigidity that people experience. There can be abdominal pain or stomach pain that may come from constipation and the gut changes that are going on. People can also have nerve-like pain in their feet from Parkinson's that may be associated with Parkinson's. And I think it's worth bringing up. Sometimes that pain seems to come cyclically at the end of a dosing cycle, for instance, and then we can modify medications to we realize that's really a Parkinson's symptom and we need to address that and treat it just as we would tremor or stiffness or slowness. Sometimes we don't want to make sure we blame Parkinson's for everything. Sometimes there's another good reason for the pain and you should still bring it up, because sometimes there's a pinched nerve, there's something else we need to do something about, or we need to send you to see someone else to deal adequately with the pain that you're having. So I think that, yes, they're subjective. I don't know the experience that someone's going through in terms of their pain. Sleep is getting a little less subjective. I definitely am getting people coming in with reports from their Fitbits, from their beds. Their Sleep Number bed gives you a report now. So I'm getting more and more objective evidence of how people are sleeping. And I think that's good. I don't know that we always have a good answer on how to treat it, but I think it is absolutely part of the conversation and we should not ignore it. We should be talking about it.
Okay. Wow. So Fitbit printouts and Sleep Number bed printouts?
Absolutely.
And technology. Like your cartoon, there's an app for everything sometimes.
Yeah, it's really amazing.
Okay, so the next question is, how can I deal with doctors in the hospital? And, oh, it looks like our screen went a little wonky. Okay, there we go. Okay, so the question is, how can I deal with doctors in the hospital? I would think, do you know what that question might mean? Or maybe we can ask a follow-up question?
Well, I can take a stab at it, and if I'm not answering it, please clarify the question. I think the first part of it is not to go to the hospital as much as you can to avoid it, but it certainly happens. I think there's a couple of things you can do. It may be referring to the issue that the doctors in the hospital, there may be internists, maybe surgeons, that you may be coming in for a surgical problem, may not understand how important the regular dosing of medications is. And I think that's true for both, for institutions in general, whether it's a hospital or a care facility or a nursing home. I think we deal with the same issues, that people do not know how important the timing is. And there are some rules in institutions that you can still be within sort of be in the right, even if you're giving medications now or before or after they're scheduled. And so that leads to sometimes some conflict, because patients really would like their medications as close to being on time as they can. And the facilities and institutions have some leeway there, and that certainly can cause some problems. So we do have, and I know our local New Mexico Parkinson's Coalition, and there's other organizations. I know there's something on different Parkinson's websites where you can download an information card that you can give to your care providers in a hospital setting that talk about the importance of using medications on time. I've certainly had patients reach out to me from using their hospital phone bed or the bed at the hospital the phone at the bed in the hospital. And I've gone and talked with the providers to make sure that people understand how important it is. I've also recommended the patients bring their medications in whatever orifice they can, right? Bring your meds with you so that you have them with you, have a care partner if they can, bring them into the hospital. And sometimes we can actually get that written as an order by the doctor that you can get your medications on time being provided by the care partner at the bedside. So I don't know if there was any clarification to the question, but I think it often relates to medications and then medications you're given that may cause interactions or side effects. And I think those are the two main things that we focus on. I think reach out to your movement disorder specialist to try to be an advocate for you. There are different kits and hospital survival cards that you can download and print from different organizations that I think can be really helpful at just reminding people this is something we have to pay attention to. This is not something that you ordinarily pay attention to, but you do need to now.
Yep, you nailed it. The question, the follow-up comment was about the importance of taking meds on time. So I think that was great feedback that, involve your movement disorder specialist or your neurologist, because I think we all know with hospitals, sometimes the patient there is not always, their word is not gold like a physician word is gold. So that's great that you intervene, on behalf of your patients, and maybe that's the solution for you. Okay, the next question is about Azilect and narcotics. So this person takes Azilect and wants to know if they have an acute injury and need a narcotic, which is the safest?
I don't know if I'm not completely stumped, I will say, by that, but I also don't know that I feel comfortable answering that question without knowing a little more about all of the medications that you're taking. I would say in general, there's many concerns about this class of medications that Azilect is in, and that's why I brought it up, that cold and cough medications can interact with it. I would tell you that most of this, just so we're all on the same page, Azilect is also known as Rasagiline. It's in the same class of medications as Selegiline, as well as the new medication Xadago or sulfonamide. They're called a monoamine oxidase inhibitor. We used that word amino acids earlier because we're talking about proteins. So our neurotransmitters in our brain are essentially proteins, and they're broken down, right? They get released, they get broken down, and then they get released again. That's the typical process that goes on in the brain. What Azilect and medications like it do are slow. They inhibit the enzyme that breaks down those medications, so it allows the neurotransmitters to be around longer. So the one we would be interested in is dopamine, right? You release dopamine in the brain. We want it to stay around longer so that you have better movement, less stiffness, less tremor. And so we would use a medication like Azilect to do that, to allow that enzyme to be not as effective so that you have more dopamine around. And in general, we think of that as a win because that gives some symptom benefit. The problem is that especially Selegiline, more than Azilect, which is maybe a little more than Xadago or sulfonamide, they also can affect other neurotransmitters, and that's where you get into the side effects we worry about. And one of the big side effects we worry about is too much serotonin being in the brain. We talk about serotonin in terms of mood because we use antidepressant medications that elevate serotonin and help mood. But if you have too much serotonin in the brain, you can develop something called serotonin syndrome, which causes high blood pressure and high heart rate. You can have a fever, and that often ends up with people coming into the hospital because it's a pretty uncomfortable situation. And sometimes we actually have to treat some of those symptoms. And so that's where many of the warnings for Azilect have come from, and why there's caution about using it with narcotic medications, cold and cough medications, antidepressant medications. I think in general practice, what I've seen with the the package insert for Azilect is, as we've gotten more and more experience with it, the safety profile has been good compared to something like selegiline that we used in the past. So I think in general, we currently use Azilect or Risagiline with antidepressant medications, right, where we would have this risk of increasing serotonin, and we just don't see it. We really see people tolerate it very, very well. So I think those kind of interactions are going to be not as worrisome for us. We think that they're actually going to be safer as time goes on. So what I'd say is I think the best thing to do would be to have your medication list, including Azilect, because there may be other things that could interact with narcotics. But in general, especially in a short term, it typically would be safe, but I ask you to get the advice directly from the person who's prescribing the medication for you at that time. But we've always had a concern about medications like Azilect because of our experience with selegiline. And there were some really adverse events from people having medication interactions. And now we think they're actually much safer, and Xadago maybe even more, have less of that interaction because it's really just working on dopamine and not those other neurotransmitters.
Okay, very good. I don't think that counts as being stumped. You're still batting 100.
Excellent.
The next
well, there's still plenty of time here.
The next question has to do with dental work. Do the medications for a dental procedure have the potential to interact with Parkinson's drugs?
So that's a good question. So there are, again, the main interactions that you would have would be with the MAOIs, that's the Azilect, selegiline, and the Xadago or sulfonamide. And so those would be the ones that you'd really want to talk with your dentist about in terms of that interaction, because they can interact with some anesthetic or anesthesia kinds of medications. But otherwise, in terms of the levodopa and the dopamine agonists, there's not really any interactions to be worried about.
Okay, very good. The next question has to do with hallucinations. Are hallucinations, can they be, I've heard that they can be a side effect of medicine or they can be a symptom. Can you clarify about PD hallucinations?
Right. So what I would say is, in general, we usually are referring to hallucinations as a side effect if you're taking the medications, right? And if it tracks with the medications. So it is not uncommon, even at low doses of levodopa, for people to start to have some kind of different sense. So we often ask patients, do you feel like there's anything in your periphery? Do you take any second glances because you thought something was there? And that's actually a hallucination. They're called presence hallucinations, and people can have those because levodopa acts in not just our motor system, but dopamine is used throughout our emotional system, our limbic system. So that's very common. And so that's absolutely driven as a side effect because we're artificially stimulating dopamine in that emotional system, and that's the byproduct of it, is a hallucination. So in that setting, that's clearly a side effect to the medication and not a part of the Parkinson's disease. That's a medication side effect. There are folks who have hallucinations as part of their disease. And in general, then that might make us think that maybe this isn't very straightforward Parkinson's disease, that this might be one of the conditions that has Parkinson's symptoms, but has some other symptoms. And the one that would be most linked with hallucinations is something called Lewy body dementia, where even without taking any carbidopa, levodopa, or dopamine agonists, or any of these other medications, hallucinations are present as part of the disease. So, and I would say that there's not, because right now we don't have a perfect test that helps us delineate someone who very clearly has Lewy body dementia versus Parkinson's disease, although we have clinical criteria and experience at helping to differentiate those. There may be a little bit of overlap there. So yes, it can be part of the disease, but generally in Parkinson's, when we're making a diagnosis of Parkinson's, we would only expect hallucinations in the presence of medications. But there are other Parkinsonian disorders that have hallucinations as part of the disease.
Okay, very good. The next question, I'm considering DBS because I feel that I'm taking too much medication and don't want to have to worry about all the interactions that you're talking about. Is DBS a good solution to cut down on medication?
Yeah, a good question. Yes, I think that is potentially one reason to think about deep brain stimulation surgery. I think right now we have certain expectations in terms of what deep brain stimulation can meet in terms of people's concerns and symptoms. One would certainly be tremor that is not adequately controlled with medications. That would be a good reason to think about deep brain stimulation surgery. When people are having fluctuations because they're taking so many doses in a day that they're really unable to do too much else, that they're every 2 hours taking a dose of medications, again, that might be a good fit for deep brain stimulation, where we can then increase the intervals of the dosing of the medications to reduce the fluctuations. And then there are times when either people cannot tolerate the medications or have a preference that they'd like to be on less medications, because again, there's not only interactions, there's a lot about timing that can take up a lot of your day, that deep brain stimulation may be a good match. The thing that you'd have to really talk about with your movement disorder specialist in terms of thinking about deep brain stimulation to meet this particular need is that there are different locations that we put the electrodes in the brain. And for some of them, for instance, the globus pallidus, it's also abbreviated as GPI, we expect, although it can help tremor and it can reduce fluctuations, that people often will stay on the same dose of medications, or actually may even end up taking more, because we can suppress some of the side effects from the medications. And that might be a good match for someone and their symptoms. There are other locations, such as the STN or subthalamic nucleus, where the expectation would be that we would likely decrease the amount of medications that people are taking with stimulation there. But there are different side effects and different risks depending on where you're putting these electrodes that you really need to balance out to make sure that your overall goal of decreasing medications is going to meet your therapy needs, and that also the side effects, you're willing to deal with the potential side effects or risk of that particular location. So I think it's absolutely on the table to talk about with your movement disorder specialist. It's not unreasonable reason to think about deep brain stimulation, but you just want to carefully make sure that all of that matches up.
Okay, very good. I think, yeah, you wouldn't want people to think that, you know, the surgery would replace the need for any medication. It's always going to be, there's always going to be a regimen, right?
In general, that's true.
Yeah. Yep. And we always have to speak about generalities, right? Because you're not looking at people's medical history.
Sure.
Okay, the next question, I guess it's actually more of a comment about exercise. So Kathleen says, I'm surprised you didn't mention anything about exercise. To me, that's the best medicine there is. So I will say that, you know, to be fair to Dr. Pirio Richardson, yep, we asked you to talk specifically about medication, but it's a good point. Can you talk a little bit about the role of exercise?
Yeah, absolutely, and I'll take that chastising. I think that's fair. I was actually, just before I got on this, my Parkinson's nurse is going to give a talk in our speech therapy, at our speech therapy group for people with Parkinson's, and she actually has, I have it in front of me because I was taking a peek at it, she wrote, also included with medicine, exercise. So she, it is something that we talk about all the time with our patients. I think it's incredibly important. One of the challenges I have is explaining what's the right exercise to do, and I don't know that we know the answer to that. There is tons of evidence that exercise, and it's been studied from walking 3 times a week, to bicycling, to yoga, to Tai Chi, to, I just finished actually a high intensity boot camp project for people with Parkinson's disease with a group at University of Nevada, Las Vegas, where they distributed patients into a high intensity and a low intensity boot camp. in order to see, number one, was it safe for people who were at a fall risk to be able to do high intensity exercise, and did we see any better improvement? All the studies universally have shown reduction of falls, improvement in gait speed, and there's some suggestion of slowing of disease progression, although that's always kind of tough to measure in Parkinson's with our current tools that we use to measure that. But point well taken, it's clearly crucial, and especially because it adds in that element of reducing falls and improving gait speeds, which, although there's lots of merits to levodopa, that is not one of its symptoms that it can improve. So I think that's exactly right. And in general, what I tell patients is you do what you can do. I think certainly there's been interest in boxing gyms, and there's some good reasons for also the camaraderie and being with people and spending time focusing on what you can do instead of what you can't do. I think all of those have positive benefits on people, and it's hard to separate, is it the exercise, what is it exactly that did it? But I think across the board, the studies have been very clear that exercise has an effect on people's walking speed and falls, and may have an effect on disease progression. So absolutely, it should be part of the day as well.
Absolutely. Okay, the next question, and we're starting to get close to the hour, so just just as a heads up, make sure to get your questions in, and we probably have time for maybe like 2 or 3 more. Okay, the next one is from, well, I won't say the name. The next one says, I'm worried that my father with Parkinson's is depressed. Is this something that I should bring up with his neurologist or something for a psychiatrist? Yes, so depression, we haven't really touched on all those non-motor symptoms of Parkinson's that tend to be incredibly intrusive. I mean, the amount of time that I spend in the office talking about constipation, which can be an incredibly intrusive and frustrating symptom for people, may outweigh the amount of time I talk about tremor. So, it is something that we really do need to pay attention to, and all these non-motor symptoms can really impact people's quality of life. And depression is certainly one of those. I think depression is something that any concerns about depression should be brought up by the neurologist, and there are many things that many neurologists feel comfortable in terms of prescribing medications or other treatment modalities might feel very comfortable instituting if they do agree that there's a diagnosis of depression and would like to treat it, and the patient's willing to undergo treatment. There are times when, either because of patient's medication regimen or I have tried intervening and have not been successful, that we might bring in a psychiatrist to help with that. And there are even a few, there are not too many out there, but there are a few neuropsychiatrists that sort of bridge that gap and actually really understand both aspects of this. I'm lucky enough to have contact with one, and it's incredibly helpful. But I think it's fair game to bring up for the neurologist. If you're dealing with someone with Parkinson's disease and you're not willing to talk about depression, which is certainly part of the disease process, I think it's something that's fair game. Okay, and that brings up a good point that maybe I'll ask you to clarify. The neurologist versus the movement disorder specialist, and if you could explain the difference, and maybe talk about, well, we as an organization, we always recommend for people to see a movement disorder specialist. So I don't want to, put words in your mouth, but that question kind of brings to light how, a neurologist, they treat, so many different kinds of conditions, and maybe, depression is something that a movement disorder specialist would be better suited to understand the complexities as it affects Parkinson's. So could you just give us a kind of an overview of the difference, and maybe your advice on which to see?
I don't know if you're priming me to get hate mail or not with that question from my colleagues, but I guess what I'd say is, so a movement disorder specialist is someone who's gone through a neurology residency, so that's 1 year of internal medicine and 3 years of neurology, of which some of that will have been spent learning about Parkinson's disease and and then all the other neurologic conditions. Then a movement disorder specialist does a fellowship, which is what we do after our residency, and that varies very much on what that training can be. But the first year is typically very clinically oriented in terms of learning about the different movement disorders, including Parkinson's disease, the medications, medication interactions, how to treat it, and then some training in surgical therapy. So some people get a lot of experience in going into the operating room and learning how to do the recordings of the brain or assisting the surgeon with the symptom management in the operating room. And then people can, sometimes people do a 1 year fellowship, and that's what they focused on in that year. Also have learned Botox injections and other things. I did a 3 year fellowship because I also am a researcher, and so I spent time working on research projects in those following 2 years in people with dystonia and Parkinson's disease. And so that can vary how much research training people have on top of that, but they've all usually had at least 1 year of clinical training in movement disorders. And you know, I'd say the most important thing is that whether you're seeing a general neurologist or a movement disorder specialist, is that you have a relationship with them where you can communicate well and you feel like they're communicating well back with you. I think many of the issues that I see when folks are coming in to see me as a second opinion often boil down to either they didn't report how the medications and symptoms were going and didn't give the provider an opportunity to make those changes, or the provider didn't reach out and really find out what kind of side effects and problems were going on in order to modify the regimen. So, I mean, I think movement disorder specialists without a doubt have extra training and extra interest in keeping up with all the advances going on in Parkinson's disease, and there are a lot, and so I think there's some advantage there. But I think, you know, with any provider that you see, that's, you know, I think the base element of why we went into medicine and also what makes that relationship work best.
Yeah, and that's a very diplomatic answer, and we always tell people too that you can see both. You know, you can see your general neurologist if you have a good relationship with them and you know them for a long time, but at times also consult with the MDS. And I think now we have Tom who wants to ask a question. So I've unmuted you, Tom.
Thank you.
Okay, go for it, Tom.
Yes, Doctor, I'm very interested in my problem is I have a static, freezing gait, and
Yes.
my problem is this: I freeze up and I can't do anything. I just can't move or anything, and so I'm really having a problem with that. And I just wondered what you can help me with that. And sometimes I can't tell when I'm on or off my medicine. You know, that's the problem. How do I tell if I'm on or off my medicine? On means by my freezing gait isn't so prevalent, right? Off means I'm really I'm going to fall all the time. So how do I tell that? Is that the only reason I can tell whether I'm on or off?
Right. So quite a few questions in there. I mean, I first would say that that symptom is really one of the hardest ones, is that freezing of gait and difficulty initiating movement. It puts you at great risk for fall. Sounds like you're having some, and I wish we had a really good, quick answer for that problem. There are people who have freezing of gait that is not affected by our medications. It's not improved, and so you may not feel that you're on or off related to that. I think in my practice, when patients are not sure, cannot answer that question of, you know, when I ask people, I say, when you take your first dose of medication, how long after do you notice any symptom improvement? How long does it last? And what are the symptoms that tell you that the medication is wearing off? And if they're having trouble telling that, it's possible that they're not on the right dose of medication to actually see improvement in their symptoms. It's possible that the symptoms they're looking for to improve will not improve with the medication. And so what I do is I actually ask people to come in the morning off medications, bring their medications with them. And we have a rating scale called a UPDRS, or Unified Parkinson's Disease Rating Scale, where we can actually look at movements and rate them, and then have people take medications and look at them again about 40 minutes to an hour after and see what might have improved or not. And that sometimes can give us an idea of we're not on the right dose, or are we talking about a symptom that's not actually going to be improved, but we can actually see some other things improve. So that might be a place to start, is actually to talk with your doctor about that if you're really unclear of whether you're on or off or seeing any difference with the medication. Sometimes that can be really helpful to come into the office off medications, bring your meds with you, and then take them so we can get another pair of eyes, and we may actually try increasing doses during the day to see if we can sort that out. Sometimes freezing of gait and gait problems can be related, can be an off symptom. They also certainly can be not responsive to levodopa, and that gets a little trickier to know what's the right way to treat that. But in terms of this on-off question and whether the freezing of gait might be an off symptom, I think the easiest way is to come in off medications, have your physician evaluate you, take the medications, and then have a reevaluation. I think that's probably the best way to sort that question.
Okay, very good. Well, that brings us to the end of our time with you today, Dr. Pirio Richardson. So thank you again for taking the time out of your busy schedule to join us. We'll let you get back to your clinic patients. And again, everyone, this was recorded. I'm going to upload it to our website and our YouTube channel. So this was such a good overview, and great questions, guys, too. You guys had some great questions. So you'll be able to share it if there's someone who you think would benefit from seeing this. And also, if you have topics that you would like for us to feature in future months, please send those to us. We want to tackle what you want to hear about. So email us, or you can put it in the chat. I'll leave this meeting open for a little bit. Next month, let's see, in the upcoming months, we're going to do one on music therapy, one on alternative therapies for PD. Actually, another New Mexico doctor, Dr. Marjama Lyons, is going to be doing that topic. And then, let's see, I think we have REM, sleep behavior disorder, as a topic coming up. So stay tuned in your email or on our website for details on upcoming sessions. But that concludes today's program. So again, thank you to Dr. Pirio Richardson, and thank you to all of you for taking some time out of your day. And, bravo for taking the time and the energy to empower yourself by getting information. I know maybe this isn't as exciting as a Netflix show, but so important, this information. So thank you for joining us for Lunch with Docs. Okay, so bye everybody.